Evidence-based methodology swallowing. Standardized process evaluation, 4. Dysphagia responding to CPT 92526. Initial evaluation will follow the protocol established by San Jose University in conjunction with the IDDSI framework and reviewed by Dr. Jose Gabriel Padin. Prepare all materials visible and accessible. All demographic information includes the date of evaluation, the patient's full name, date of birth, chronological age, medical ID number, the location of the review, and the time. Remember, the assessment is a process to determine decision-making and implementation, according to medical necessity. The methodology is comprehensive and covers all aspects of human development, whether child or adult. The evaluation process starts by determining the patient's status, starting with overall biological, psychological, sociological, and environmental cultural aspects. The biological factors in feeding and swallowing. Biological factors encompass the physical and genetic attributes that influence a child's development, including feeding and swallowing abilities. Key aspects include anatomy and physiology. Developing oral structures such as the mouth, tongue, and throat is crucial. Proper muscle function and coordination are essential for effective sucking, chewing, and swallowing. Neurological development. The nervous system's maturation affects motor skills and reflexes in feeding and swallowing. Conditions like cerebral palsy can impact these functions. Genetic factors. Genetic conditions, such as cleft palate or Down syndrome, can influence feeding abilities due to structural anomalies or muscle tone issues. Health and nutrition. Health affects feeding, including growth and nutritional status. Malnutrition or specific deficiencies can impair development and function. Psychological aspects include emotional and cognitive development, influencing a child's feeding behavior and experiences. The key components are attachment and bonding. Positive interactions with caregivers during feeding can promote a secure attachment, which is vital for emotional well-being and a positive feeding experience. Stress and anxiety. High stress levels or anxiety in children or caregivers can affect feeding. Children may develop aversions or have difficulty with eating due to negative experiences. Learning and behavior. Feeding involves learned behaviors and skills. Positive reinforcement and modeling can encourage healthy eating habits and appropriate feeding skills. The sociological factors in feeding and swallowing. Sociological factors encompass the broader social context within which a child is raised, affecting feeding and swallowing development. Important aspects include family dynamics. Family structure and interactions play a crucial role. Supportive, consistent routines and positive mealtime interactions encourage healthy feeding behaviors. Cultural practices. Different cultures have unique feeding practices and dietary preferences, influencing what and how children eat. Cultural norms can also affect attitudes toward feeding and food. Social support. Access to social support, such as extended family, community resources, and healthcare services, can influence feeding practices and assist in case of feeding difficulties. Regarding the environmental and cultural factors, environmental and cultural influences on feeding and swallowing. Environmental and cultural factors include the physical surroundings and cultural context that shape a child's feeding and swallowing development. Key elements include physical environment. The availability of safe and appropriate feeding environments, such as clean water, proper utensils, and suitable seating, is crucial. Exposure to toxins or pollutants can negatively impact health and development. Socioeconomic status. Economic conditions can affect access to nutritious food and healthcare services. Children in lower socioeconomic settings might face higher risks of malnutrition and related feeding difficulties. Cultural beliefs and norms. Cultural attitudes toward food, mealtime practices, and feeding methods vary widely. Cultural beliefs can influence dietary choices, breastfeeding practices, and responses to feeding issues. Most relevant is that media and technology play a significant role. Exposure to media can shape feeding habits and preferences. Advertising, educational content, and social media can all influence children's and caregivers' attitudes toward food and feeding practices. An essential part of the evaluation involves assessing the potential of oral motor capabilities. This assessment focuses on the strength and proficiency of the facial muscles and cranial nerves involved in the swallowing process across all three phases: oral, pharyngeal, and esophageal. The screening and understanding of the senses involved in feeding and swallowing are crucial. Deficiencies in any of these senses can create obstacles in the evaluation process. Important to note that if in recent years, health has been highlighted as a significant issue, suggesting it may be part of the problem rather than solely linked to a feeding issue that requires medical intervention. A comprehensive overview of nutrition problems in recent years, highlighting their significant impact on feeding and swallowing difficulties. Very important to investigate if notable nutrition concerns related to food allergies are important due to health and safety issues, which help minimize the risk of emergencies. Most swallowing and feeding disorders are secondary to underlying medical diagnoses or primary disease processes. Accurately identifying the specific etiology is essential to implementing targeted interventions that align with established medical guidelines, ensuring the condition is managed appropriately without exacerbating the patient's overall clinical status. Psychological factors play a significant role in developing and managing feeding and swallowing disorders. Emotional and behavioral responses, such as anxiety, stress, sensory sensitivities, food aversions, and past traumatic experiences, can influence a patient's willingness or ability to eat and swallow safely. In pediatric populations, feeding difficulties are often exacerbated by learned behaviors, parent-child interactions, and environmental stressors. In adults, conditions such as depression, post-traumatic stress disorder, or cognitive decline may contribute to reduced appetite, oral motor control, or swallowing safety. Assessing receptive and expressive language proficiency is critical to comprehensive feeding and swallowing evaluations. Adequate receptive language skills are necessary for understanding instructions, safety cues, and mealtime routines, while expressive language supports the individual's ability to communicate preferences, discomfort, and needs during feeding. Sociological factors play a crucial role in evaluating and intervening in feeding and swallowing disorders. These influences extend beyond medical or physiological aspects and directly impact patient engagement, caregiver participation, and treatment outcomes. Family dynamics, including caregiver responsiveness, mealtime interactions, and parental stress, can either support or hinder the feeding process. Inconsistent routines, overdependence, or conflict around meals may contribute to feeding refusal or maladaptive behaviors. Cultural practices. Cultural and religious traditions often shape mealtime behaviors, food choices, and feeding practices. Some families follow structured mealtime routines based on cultural or religious customs, while others may adhere to more general habits unrelated to specific traditions. In certain cases, families may lack a consistent mealtime routine due to factors such as varying work schedules, time constraints, or lifestyle habits. It is essential to approach these variations with cultural sensitivity and to respect the family's preference if they choose not to disclose details about their mealtime dynamics or interactions. Social support systems, such as extended family involvement, school staff, or community programs, enhance consistency and reinforce therapeutic strategies across environments. Lack of support often correlates with increased caregiver burden and reduced therapy adherence. Cultural practices significantly influence feeding expectations, food choices, mealtime behaviors, and caregiver perceptions of feeding difficulties. Culturally responsive care is essential to respect family beliefs while introducing evidence-based strategies, ensuring both acceptance and effectiveness of the intervention plan. Understanding and integrating these sociological elements is fundamental to creating individualized, holistic treatment approaches that are sustainable and meaningful within the patient's social and cultural context. Understanding protocol logistics in assessing swallowing disorders. The materials and equipment checklist outlines all essential tools and resources required to initiate the initial phase of a structured feeding or swallowing evaluation. This checklist ensures all necessary materials are available and appropriately prepared to support safe, evidence-based assessment. The selection of consistency samples during a swallowing evaluation is critical for accurately assessing an individual's swallowing safety and efficiency across various textures and liquid viscosities. This process helps identify which food and liquid consistencies can be safely consumed without increasing the risk of aspiration, penetration, or residue. Different consistencies, from thin liquids to purees, mechanical soft, and regular solids, engage distinct swallowing mechanisms and challenge oral, pharyngeal, and esophageal phases differently. Testing a range of textures allows the clinician to 1. Evaluate bolus control, transit time, and airway protection. 2. Detect any signs of dysphagia-related complications such as coughing, throat clearing, wet vocal quality, or delayed swallow. 3. Recommend appropriate diet modifications based on objective evidence. 4. Guide individualized treatment plans and therapeutic exercises. Inappropriate or incomplete consistency selection may lead to misdiagnosis, underestimation of risk, or unsafe diet recommendations. Therefore, consistency testing must be tailored to the patient's medical status, age, cognitive level, and feeding history, while following standardized frameworks such as the International Dysphagia Diet Standardization Initiative, IDDSI. Standardized process, progressive swallowing evaluation integrates objective instrumentation with the speech-language pathologist's clinical competencies, grounded in the principles of neurophysiology. This approach ensures that the swallowing assessment is both evidence-based and functionally relevant. In Phase 1, the SLP must establish and adhere to essential preparatory procedures to ensure accuracy and patient safety, ensuring appropriate positioning and alertness of the patient, preparing all necessary materials and instrumentation, and reviewing the patient's history of feeding, swallowing, and neurological status. This includes: follow medical orders and clearance, and check for food allergies, as instructed. Have SLPA, RNLPN, dietitian/nutritionist, or director of nursing available when possible. Set an evaluation table following all PPE, disposable surfaces, OSHA, and safety guidelines. Cognitive screening. For example, a token test following 2-3-5 oral commands or color blocks, small toys, and objects. Oral motor examination includes DDK rate, MPT or tests PEF and FEV1. Electroencephalography, EEG, non-invasive. Goniometer as needed, depending on NDDX and/or HX. Monitor the oximeter. CPR and rescue RN are available. Protocol Phase 2 instructions. Provide the patient with information and instructions. Using an oximeter, establish a baseline spirometer, risk indicator, and 300 flow meter tests PEF and FEV1. Setting up all 6 consistencies. Use the same procedure for all consistencies. It is a progressive standardized methodology. Place 3 fingers over the larynx for a tactile examination. Monitoring electroencephalography, EEG, activity and changes. Monitor the oximeter for each presentation to see if there is a decline from the baseline of 2% SpO2 or more. Stop. Stop. Once consistency determination has been met. Do not continue with other consistencies unless required to complete all consistency presentations to define your consistency baseline or determination. Electroencephalography, EEG, is a non-invasive method used to measure electrical activity in the brain. While EEG is not traditionally a first-line tool in standard dysphagia evaluations, like FEES or MBS, it is increasingly used in research and neurorehabilitation to better understand the neural mechanisms of swallowing and support neuroplasticity-based interventions. Delta, theta, alpha, beta, gamma. A spirometer risk indicator is a clinical tool for assessing lung function and measuring key breathing parameters. A 300 flow meter test, PEF and FEV1. PEF indicates the maximum speed of exhalation, reflecting airway obstruction. FEV measures the volume of air forcefully exhaled in the first second, used to assess the severity. Protocol Phase 3 sample consistency presentation. During a swallowing evaluation, it is essential to present a variety of consistencies to assess the safety and effectiveness of the swallowing mechanism. The following samples are typically tested in alignment with the International Dysphagia Diet Standardization Initiative, IDDSI, framework or facility-specific protocols. Protocol Phase 4. Monitor the oximeter. In Phase 4 of the feeding and swallowing protocol, continuous pulse oximetry monitoring is implemented to assess oxygen saturation, SpO2, levels during oral intake. Monitoring SpO2 provides real-time physiological feedback and is a non-invasive indicator of potential respiratory compromise during swallowing. Importance. 1. Detects oxygen desaturation that may signal silent aspiration, especially in individuals with impaired airway protection or reduced laryngeal sensation. 2. Assists clinicians in identifying early signs of swallowing-induced respiratory distress. 3. It supports clinical decision-making regarding safe intake levels, the need for texture modifications, and therapeutic strategies. Clinical implications. 1. A drop in SpO2 of 2%, 5% or more from the patient's baseline during feeding may indicate airway invasion or inadequate coordination between breathing and swallowing. 2. Persistent or delayed desaturation post-swallowing should prompt further evaluation, e.g., instrumental assessment like FEES or MBS. 3. Oxygen monitoring is critical for patients with neurological disorders, respiratory conditions, or medically complex cases. Degree of eye watering. Observe and document if eye watering occurs during or immediately after swallowing. Note the timing, frequency, and whether it coincides with specific consistencies or volumes, as this may indicate discomfort, airway compromise, or increased swallowing effort. Signs of choking and/or discomfort. describe the onset, triggers, and behaviors observed, e.g., coughing, throat clearing, facial grimacing, refusal to eat. Identify when these signs occur, before, during, or after swallowing, and under what conditions, e.g., specific textures, as they may signal dysphagia or aspiration risk. Treatment implementation and possible recommendations. If necessary, once the evaluation is completed, a study might be required based on the following. Differentiated diagnosis. Given the results, the patient is not a candidate to receive treatment, the risk is very high. MBS or FEES study as required. Diagnostic impression ICD-10, identified challenges, phases implementation 1 to 2 and 3. POC adjustments to dietary consistency and swallowing therapy. Referral to a dietitian for calorie intake evaluation. Written guidelines for the nutritionist, director of nursing, and kitchen staff. Instructions are displayed on the communication board. Training for caregivers and staff. Additional modifications or compensatory strategies. Other referrals as necessary. In summary, to have a patient participate in a swallowing and feeding program, an SLP-CCC must complete the evaluation process, including all 4 essential phases. Step 1, Feeding and Swallowing Input Eligibility Criteria for Direct Intervention. Guidelines for SLP Providing Swallowing and Feeding Services, ASHA 2007, to qualify for medically necessary treatment for swallowing and feeding difficulties caused by neurological, developmental delays, or psychological reasons, an individual must meet the following criteria: focus on interdisciplinary decision-making and categorizing swallowing and feeding disorders. The 2023 Florida statutes, including Special Session C, Medical Necessity. Step 2, Evidence-based methodology, swallowing standardized process evaluation dysphagia responding to CPT 92526. Step 3, create a menu consistency plan, following the International Dysphagia Diet Standardization Framework. The dysphagia diet has levels that rate drinks and foods on a thickness scale from 0 to 7. Step 4, diagnostic and intervention, feeding or dysphagia approach. The scientific purpose of treating patients with swallowing and feeding difficulties is to promote safety, health, nutritional adequacy, quality of life, functional independence, prevention of complications, and adherence to evidence-based practice. ASHA 2024. The overall summary of results, including detailed observations and descriptions, is essential for accurately diagnosing feeding and swallowing disorders, implementing appropriate treatment, informing referrals, and supporting evidence-based clinical recommendations. This concludes the presentation of evidence-based methodology for swallowing, standardized process evaluation by Dr. J.G. Padin, board-certified SLP by the American Speech, Language, and Hearing Association. For more information, feel free to contact by email to padinagabriel@gmail.com.